Faith invited me to come over here today, and also delighted that my colleague Rhonda Byrne could come too. So what we're hoping to do during this hour is talk a little bit about the work that we've been doing. I've been working on this since the mid-90s when I was a student nurse midwife, and then I've been able to have a research career. So most of what I do is research, and so I want to sort of tell you the story about how our program of research has unfolded and what we're learning, and why taking a trauma-informed approach in working with women and families is so important right now. I've thought it's been important for a long time, but now we're really building the evidence base that shows that it's really extremely worthwhile, and I'm hoping that our research is going to be able to give you the fuel you need to be able to carve out the type of services that will really be helpful to these families. So my focus has been on post-traumatic stress and childbearing, and I'm going to give you the take-home points first in case this turns interactive and I don't get to the end of the talk, okay? So the first thing I want to let you know is that post-traumatic stress disorder affects more than 1 in 10 pregnant women, actually. So it is important. It's just that we didn't have a lens to see it before. So it is something that's going to end up, as people become more aware of it, becoming a more important part of the services that you deliver. But the other thing that's important to know is that there are comorbidities, risk behaviors, and associated features that are also in the clinical picture. So during the childbearing year, some women will do well with frontline services. So integrated primary mental health models are going to work really well in primary care settings. But some women are also going to need specialty care. And so it's going to be really important to have interdisciplinary collaborations and networks built. The structures that have been created to deal with perinatal depression are probably also going to be well suited to dealing with PTSD when you want to make a referral. But the really important thing is that referral is not as adequate for PTSD as it is for depression, because the nurses, midwives, or physicians who are providing physical care to women are actually going to be in situations where some trauma reactions get triggered, and they actually need to be well equipped to deal with it right at the time that it's happening if they want to help the woman in an optimal way. So more maternity care professional involvement will be needed because of triggers. The other thing is that when women become pregnant, they can be anywhere on their process of recovery. So some women will just be overwhelmed and have a lot of coping to do. But some women will be fairly far along, and for them, post-traumatic growth is a very feasible goal to have. And the focus can be on stopping the intergenerational cycles of abuse and trauma and vulnerability. So again, although I think you probably already do a ton of it, I didn't know for sure who I'd be speaking to today, and I just wanted to emphasize that interdisciplinary collaboration is really, really important. So just to tell me a little bit who you are, how many of you are nurses? Okay, and social workers, outreach workers, obstetricians, midwives? Okay, so you folks are the frontline people, and what's going to end up happening is there aren't so many of the bedside people here, so I hope that you will be taking away some ideas for how to help them. So the first thing that I try to say, hopefully when there's a mixed audience, is that it's really important to let the borders of the problem and not the boundaries of our disciplines or professions determine how we shape the solutions for this problem. So, basically, we end up having what look clearly like mental health problems, including PTSD, depression, interpersonal sensitivity, somatization, and sometimes dissociative reactions that are happening that psychiatric professionals would recognize and be focused on. But beyond the psychiatric aspects, there are also many trauma-related concerns, and some of those are purely social concerns. Issues about the woman's safety, lack of support from family of origin, often by choice, where the woman is distancing from a family of origin that's not safe or not supportive. And also parenting concerns, as those of you who work with infant mental health know very well. So we really need to make use of a whole team. Well, okay, so one of the things I like to tell people is, how did I get started studying this so early? In my checkered professional career, I was a high school teacher to begin with, and I studied French literature. And in literature, the stuff that I liked the best were sort of the creepy stories from the turn of the century. They wrote a lot of ghost stories, and there was a lot of stuff that was really dark. The first detective novel written by Wilkie Collins was actually a story of domestic violence. But back then, it was a lot more subtle than what we see on Oprah these days, and so you had to be reading kind of with a net to catch the hints of what was happening in these domestic situations. So when you're a reader, you suspend disbelief and you take in the narrative because your only response to it is to enjoy the story, basically. But when you're a healthcare professional, that's not the case. You're responsible for having some sort of response when this information comes at you, including, mandatory reporting responsibilities. So I think that healthcare professionals have a tendency to not want to see because they're very concerned about opening a can of worms. So when I was a young nurse and a nurse midwife in training, I saw women who seemed quite traumatized to me. I worked with a very vulnerable population in Toledo and in Detroit. And I kept asking people, what could be done? And basically, at that time, which is, around 1991, 92, 93, there was really nothing in the literature. There was no evidence base for anything, and people really didn't even seem to have clinical wisdom to pass down.